Hello, everyone. We are back for another great conversation, and I'm very excited about our guest today. MaryAnn, why don't you introduce our guest?
Oh, absolutely. And I too am really excited about our guest. We have today with us Dr. Eric Tesoriero. He's a board certified critical care anesthesiologist in private practice with St. Luke's University Health Network in the Lehigh Valley in Bethlehem, Pennsylvania. He's also board certified in neurocritical care. He completed a fellowship in Beth Israel Deaconess in Boston in 2016, went to St. Luke's, and has been in practice there since then. He's the medical director for their Monroe campus ICU, and he's medical director of their PBM program in network. His current projects include preoperative anemia management, standardized care across joint arthroplasty and hip fracture management, management of anemia in antepartum and postpartum women. Go, Eric. His hobbies include home maintenance, cooking, grilling and smoking, and baking cheesecakes, reading, and running. He's also married to an emergency room physician, and they have two children, 5 years old and 2 years old. So it sounds like you're a busy man. So we really appreciate you coming here to speak with us tonight. Thank you so much.
Thank you for that kind introduction. Good evening. Well, Happy New Year.
Yes.
Happy New Year.
Happy New Year. You know, the audience probably does not know this, but this is actually the second time we've recorded with you. We have a recording in our archives. You were among the first who volunteered to be a guest for us. But by the time that we got to the production of your recorded podcast, we had already moved on to video. And so we've been wanting to have you back for a full year, and we're glad that we finally caught up to you. We thought this time, though, that we would talk about a recently published paper that you were part of. And congratulations, the list of authors on this paper are PBM giants, I would say, and you're among them. The title of the paper is The Determination of Unnecessary Blood Transfusion by Comprehensive 15 Hospital Record Review. So we're very excited to talk to you about this today.
Stellar. Love it. Congratulations.
I'm honored to be one of your guests now in 2024 and to be one of your, early recording guests. And I'm sorry that we didn't get to use that recording, but I'm glad to be here now.
Definitely.
Thank you so much. Yeah, and we're so glad to have you. Very appreciative. Tell us about this paper.
Well, I certainly stand, on the shoulder of the giants that you mentioned there. Dr. Jabin, Dr. Waters, Dr. Shander, and all the other folks who are involved in this collaborative. I think that many of us in the PBM community have no doubt in our minds that transfusion is an overutilized medical procedure. And certainly in 2012, when the American Medical Association put together, that was one of the 5 overutilized procedures in medicine. Everybody knew that, and everybody wasn't surprised to hear that. But what's novel is that since then, much of the work has really focused on randomized controlled trials with liberal versus restrictive transfusion thresholds in certain specific patient populations or in certain specific patient locations, whether it be in the ICU, whether it be within certain subgroups. And really the dialogue is focused on this hemoglobin threshold versus that hemoglobin threshold. Looking forward now, this is one of the first papers to take a look comprehensively and try and take a retrospective review of the transfusion practices of hospitals. And like you said in the title, 15 hospital systems participated in this review and analysis of their work. And, when you talk about that, 15 health systems participated in this. 3 are for profit, 12 were not for profit, 3 were independent, and there were several faith-based institutions in there as well. All were in the United States. A lot of work has already been done internationally highlighting the success of PBM as a whole. I think we could really credit Western Australia and Europe with showing us at a health system level what benefits there are. But, in the US, we don't have that data, and we need to prove it for ourselves sometimes. And so these 15 hospital systems participated and provided data on patient encounters. And each submitted about 100 patient encounters over a certain period of time to get to a certain quota of patient encounters. And in total, there were 1,568 transfusion encounters that were, included in the analysis. And then they were reviewed by the 2 experts on the paper and subsequently reviewed by a team of patient blood management experts, and they were reviewed in the way in a context to see whether or not there was PBM opportunities and to generalize whether the care that was rendered and the transfusion practice that was done was appropriate and or could have been done without or with less blood.
And I know a big discussion in the paper was computerized provider order entry. And so for our guests, can you tell them what computerized provider order entry is and how you use that tool and how it's made medical practice in general better?
Sure. I think that one of the big questions in medicine, especially if you're not in it, is how do we get from the therapy that the provider or the physician is thinking to actually executing that therapy, whether it be a pharmaceutical or whether it be a procedure or something. And in all of those cases, we use a computer provider order entry interface, which is just a fancy way of saying there's a computer interface to enter an order. I want to just reflect for a second that historically, this CPOE was a piece of paper, and your pen was what you did there to get it onto that paper, and then that order had to include all the critical details that were necessary in order to give that therapy. So if it was a pharmaceutical agent, you'd have to put down the drug, the dose, the route, the frequency,
Yep.
and you'd have to have all that information there. Hopefully it was in a legible handwriting so that when
For sure.
the nurse reviewed that order, that it was legible. When it got faxed down to the pharmacy, they could review that, and then it could, be acted upon. I think we could all work with the doctor stereotype that we have terrible handwriting, and I fully own that one.
Yep.
Yes.
But in all seriousness, there are many opportunities to improve patient safety with just digitizing that process. So for example, just using a pharmaceutical example, we can have a lot of safety built in by just clicking a common medication and referencing the typical dose, route, and frequency that's there. So all of that is standardized, minimizing medication errors. Many health systems have gone further than that, though, and actually made it so that drug-drug interactions are picked up. So drug A and drug B are there. There needs to be modifications to the dose or frequency, or these should be completely avoided under all circumstances. Drug-food interactions are highlighted, and drug-disease state interactions are highlighted. Now, one of the real challenges, though, is that blood is not a drug, right? And so we use the same order entry interface for a organ transplantation as we do for ordering any of our other medications or monitorings.
So, just to be clear, CPOE is just the process of entering orders, but health systems can now add some sort of complex logic to help with decision making while you, as the provider, are entering the orders.
That's exactly right.
Okay.
And yet, even though we have computerized aided way of entering orders, it's definitely made our lives better. Clearer communication, nurses having to less calls to contact you to say what did you write here, what did you scribble here. Definitely it has made all of our lives better. And yet in your review you're saying that 90% of blood order entry is possibly overuse of blood. So is computerized provider order entry making things too simple for physicians in that maybe they're not thinking about patient blood management?
Yeah, I think that one of the challenges is the decision about whether or not a patient needs a transfusion is a complicated one. And there's a lot of variables that go into that. And the real challenge is to get all of those variables to be in the same place and the same time to be put on the scale together to decide whether that therapy is or is not appropriate. So, like I said, for provider order entry, from a medication perspective, they do a reasonable job of putting a lot of information there. If there are lab changes in kidney function, we can see that we should change the dose of certain medications as appropriate. And it does a really good job of helping with the decision logic on simple things like a hemoglobin threshold, but it doesn't do a good job
Mhm.
of overarching, have all metrics of patient blood management being incorporated. So I think that many health systems have had great success with just a simple alert. Hey, the patient's hemoglobin is, you know, 8.5. Are you really sure you want to do this? Are you really sure you want to give them blood today?
Mhm.
And have an alert and be really, intrusive there. I think that that's the low hanging fruit that can be eliminated with computer provider order entry.
Don't all providers know about patient blood management and when you should and shouldn't transfuse different products, or is this an opportunity for education within the CPOE?
I wish that there was more education for every provider on patient blood management. I think that it's clear to me on a daily basis that not everybody has this information, unfortunately. I think that unfortunately it doesn't get a lot of time in medical school education. It doesn't get a lot of time in postgraduate education. And you're really limited on whether or not your attendings have exposure to it or you happen to be exposed to it in your training. An
Mhm.
interesting study from Beth Israel Deaconess Medical Center looked at the knowledge of the trainees there. So, whether it be interns, residents, fellows, and attending physicians in transfusion medicine. So, not patient blood management per se, but transfusion medicine. And there is obviously a little bit of overlap in some of that content. And obviously, as they got further along in their training, there was greater knowledge competency, but the knowledge gaps persisted all the way through the fellow level. And obviously expertise was
Sure.
viewed at the attending level. So that highlighted that transfusion medicine knowledge was not there.
I read that some of the participating hospitals, they had PBM programs, and yet we still have these results of overtransfusion, correct?
So that's correct. All of the hospitals that participated felt that they had good practices regarding transfusion, interestingly enough. Several had strong and robust
Nice.
patient blood management programs in place already. Many had processes actually in place where they had some prospective order review process, but none provided documentation as to what that process actually looked like for us to know as we're reviewing different system practices.
That was a really great question, Sarah. Yeah, and you have me thinking about, so we can put this logic in and help people along the way, but sometimes that can be negative also, right? Like we put in sometimes, do not transfuse until hemoglobin of 7. Does that cause any negatives there, or like help people lose their critical thinking skills?
Well, I think you ask a really interesting question, and it's did we see in this review, was there any incidents that we didn't treat patients we should? And there was no evidence at all that we avoided treatment when we should have treated patients. So there was no under
Hmm.
treatment at
Oh,
all
that's great.
and only over treatment identified. And obviously, over treatment with blood products is associated with risk.
Yeah.
Hmm.
So you mentioned that this paper was a retrospective chart review, which means that we've looked back after some time has passed and looked at transfusions and seen was going on and whether or not we transfused appropriately. And you just mentioned also prospective order review. And I know that not many organizations do this. That is basically reviewing the orders as they come in real time to check for appropriateness. But MaryAnn, your hospital, Geisinger, you do a prospective in real time order review of transfusion orders. Isn't
Yep,
that correct? And has that really helped your practices?
it has. And I think that the ideal mix is having a good PBM program and transfusion services where you can use this logic that Dr. Tesoriero is talking about and help initially with the clinical decision making, guide people along, and look at a review afterwards to see what's been happening. But also, as you noted, we have a prospective review, which we're so fortunate to have. We really have a lot of fun doing it. But we have transfusion guidelines in place, and we have the blood bank folks give us a page through Tiger Connect and say, hey, take a quick look at this chart. So anything that's ordered outside of our pre-established transfusion guidelines gets a page, and we review it, either myself or one of the resident pathologists, and we say yes or no. And of course, this has been iterative. Like we learned, don't call us if it's a mass transfusion or somebody's in the OR. Like we'll just let it slide for now, certain situations like that. But it's been really good. We've had some really good educational moments with various types of providers, and we've really cut down on what we call inappropriate or unnecessary transfusions along the way. It's been very exciting. Yeah.
And Eric, to clarify, when they say 90% of the charts may have been inappropriate, they're not saying that they're not making a determination that they were inappropriate, correct? They are identifying that maybe there were some missed opportunities in 90% of the cases.
So that's exactly right. There were missed PBM opportunities that led to the patient needing a transfusion. And, in that 90% that you're talking about 45% when reviewed by that expert committee group were felt to be able to be managed without transfusion at all. And 46% were felt to be able to be managed with less blood products than they received, for nearly 91 and change percent being able to be managed with less blood or without blood products than they receive. I think it's a good way to look at this and think about this is through a patient story for a moment. And this was, an example that was utilized in that system. A patient presented for an elective surgery. They had preoperative blood work that showed that they were anemic, but they proceeded with a major operation. And then post-operatively, they were anemic and they had a symptomatic anemia with, orthostatic hypotension, tachycardia, and were transfused. I think that depending on the lens that you want to look at this, that transfusion meets those guidelines and would be viewed as appropriate.
Mm-hmm.
But that transfusion was entirely preventable. So
Mm-hmm.
we
Yes.
did that patient a disservice, and that appropriate transfusion was preventable with good PBM that was missed. Namely in this case, appropriate preoperative workup of their anemia.
I think what we could take from that is when you're building this logic into the CPOE, you can build in statements like, did this patient have an anemia workup? Did they, did you identify why they're anemic, and so on, and have people check the list, not to a state of fatigue, but, just some quick checks to ensure that, they do need this blood and they have been evaluated.
Yeah. Dr. Tesoriero, could you give us some examples of how you think CPOE could be improved and maybe catch more, help physicians with their ordering of products, blood products?
I think overall medicine is full of a lot of data points. And the hardest part of all of those data points is being able to put and figure out what's the signal and what's the noise. And obviously, we have
Mm-hmm.
more and more data points every day. So, how do we put together the critical pieces of information related to blood health and anemia and patient management and putting those all in front of you in the right screen at the right moment? Seeing appropriate anemia related studies when that patient's in front of you for a preoperative workup is important, having those all on the same screen. And then conversely, when they're in the hospital and acutely bleeding, seeing the right data in front of you and seeing vital signs at the same time as seeing a hemoglobin would be very helpful. And at the same time, even seeing whether or not they're
Mm,
tolerating their antihypertensives. I think that if they're normally on 3 blood pressure medicines, getting all 3 blood pressure medicines with a hemoglobin in the sevens, transfusion's probably not the answer. It's modifying their blood pressure medications.
mhm. Very good.
So I
Yeah.
think that the overarching answer is, how do we figure out a way to leverage all the data there? I know, at least in the Epic system, that there is a lot of work being done trying to put together a lot of these variables in the background. They have something called a deterioration index scoring, and that has actually been validated to show and prove when patients are going to have decompensations earlier. And so I'm hopeful that other disease states will, be able to take advantage of some of these AI tools in the background.
Mm,
Oh, that's awesome. I didn't know about that. Yeah,
yeah.
I'm going to look into that. So, quick question. Backing up to the reviews, did you come up with, I know you probably had some expected results. You said, oh, we figured we'd see a couple of these, double order transfusions or what have you. But were there any surprises that you came across?
For me, and I think the group as a whole, I think that one of the biggest surprises is that only 8% of transfusions of red blood cells are appropriate. I think that we all view that there was opportunity there, but no one thought that there'd be that magnitude of opportunity.
Dramatic. Yeah.
Hmm.
Yeah. If you look at, other blood products, the way it was analyzed, plasma and cryoprecipitator together, their appropriateness was nearly 25% and platelets was 30%. While those are
Wow.
higher numbers, they're still not very appropriate as a whole, highlighting that
Mm.
there's a lot of opportunity within patient care to employ greater PBM metrics.
Yeah, it really does outline the task of education. I mean, there needs to be massive education because obviously, we're still over using a product that does have risk associated with it.
Hmm.
So,
Absolutely. And they were able to put some other interesting data together, and they were able to look at discharge hemoglobin and really look at that on a graph. And what's interesting is that there's a median discharge hemoglobin in the nines of patients who were transfused, and that would obviously still further highlight how much opportunity that there was in patient care.
can you expand on that thought a little bit more?
Sure. So for a patient who was transfused, so what they did was they looked at the discharge hemoglobin and they looked at the number of red cell units that patients were given. And obviously we wanted to see, ideally, that the patients were given blood products around the reasonable hemoglobin threshold as accepted by current
Hmm.
guidelines at the time. And we were seeing that that was still well above those guidelines. Everybody would agree that a hemoglobin of 9.4 doesn't match guidelines for transfusion
Hmm.
practice.
Sure.
Mm, gotcha. And so, what do you think, Dr. Tesoriero, the big takeaway is for all of those who are listening to our podcast today?
I think the biggest takeaway is that there's still a lot of work to be done with integrating PBM into the care of hospitalized patients and ambulatory patients. We need to leverage our electronic medical record to put the right information in front of us at the right moment in time and highlight those opportunities for us. I think it's now a couple weeks old, but I think I remember seeing one of your posts that there was a commentary about the detection for iron deficiency anemia being something that was so missed because there's no test for it. And the test is there. And, this question's over hundreds of years old. The test is a simple blood count and then index of suspicion. So we need to have a higher index of suspicion and recognize that, anemia is under-recognized because of the ability to tolerate the symptomatology until it is so bad when it is not tolerated. So I think that
Yeah.
overall we need to ensure that PBM sees its way into the health systems further and further and in front of every patient and in every clinician's toolkit.
Love it.
We really appreciate you coming back for yet another conversation. We hope we have future conversations with you. Thank you so much.
Absolutely.
We hope you enjoyed this conversation and found some takeaway or new thought that improves your health. We would love to hear from you. Feel free to reach out to us on our website if you'd like to see what we're up to. Our website is letstalkpbm.com. If you enjoy our conversations, please like and subscribe wherever you listen to podcasts and on our YouTube channel.
Special thanks to our guest and our producer, Delaney Coronado, and the entire production team for all of their expertise in content creation, technical abilities, and dedication to our message. We appreciate the experts who drive this medical movement forward, and our affiliate partnerships who support the work that we are doing. Until next time, stay connected to your blood health.